Is it okay now? Can everybody see it?
Yeah.
Yeah.
Yes.
Good evening. I'm going to do this talk on ECG interpretation in acute coronary syndrome. First of all, you all know from last week's lecture that acute coronary syndrome includes a spectrum of conditions, including unstable angina and acute myocardial infarction, of course, even sudden cardiac death. Acute myocardial infarction can present as either ST elevation myocardial infarction or non-ST elevation myocardial infarction. Just to recap on pathogenesis of acute coronary syndrome, you all know most of the time it occurs due to atherosclerotic plaque disease. Because of either plaque rupture or erosion, there can be thrombus formation inside the artery. If the total circulation is cut off, then you get ST elevation MI. If the occlusion is partial, you get non-ST elevation MI. Even without thrombus formation also, you can get acute coronary syndrome. Most of the time it is due to coronary artery spasm. Because even though my topic is ECG interpretation in ACS, last time I think it was mentioned that diagnosis will be mentioned done in this lecture, so I will briefly take you through the diagnosis of acute coronary syndrome. It's mainly depends on the clinical features and the investigations like ECG and biomarkers. So the clinical features, history and clinical presentation, most of the time they present with acute chest pain. That's the most common symptom. People present with angina type of pain, and there can be several presentations of angina in acute coronary syndrome. Usually it is anginal pain which is prolonged, lasting more than 10 to 20 minutes, and that occurs at rest. Or it can be new onset angina of class 2 or 3, or it can be recent worsening of previously established stable angina, or it can present as post-myocardial infarction angina. As you all know, these things, medical student stuff actually, you all know the typical chest pain is retrosternal sensation of pressure or heaviness, so it can be a burning type of pain that radiates to arm, neck or jaw or the back, and it can be intermittent or persistent and can be associated with other symptoms like sweating, nausea, dyspnea, syncope, and sometimes they can present with simple shortness of breath as well. So before we come to the ECG, I just want to mention briefly about the biomarkers. Biomarkers actually help us in not only in diagnosis, but also in risk stratification of acute coronary syndrome as well. Common biomarkers are troponin, creatinine kinase, and myoglobin. Out of them, troponin is the most specific one. So we use troponin, and these days we use highly sensitive troponin also. There are a lot of conditions where troponin can be elevated. These conditions, not necessarily acute MI. You can go through the list. And there is this algorithm of diagnosis, actually rule in and rule out algorithm, mainly for non-ST type of acute coronary syndrome. ST elevation acute coronary syndrome is easy. Patient present with chest pain, ECG will be done, and if it shows ST elevation, then they go into the ST elevation MI pathway. But in non-ST elevation MI, sometimes diagnosis is not that easy, and the algorithm involves doing when a patient presents with typical symptoms, doing troponin. Better to do high sensitive troponin at 0 hours and 1 hour, and maybe at 3 hours. And depending on that, we can rule in or rule out non-ST elevation acute coronary syndrome and plan for further management and investigations as well. I just want to mention briefly about risk scores also. The common one we use is risk calculator, using many clinical parameters and investigations also. These risk calculators are used to assess the cardiovascular mortality risk during acute coronary syndrome. So this is the proper lecture. ECGs in acute coronary syndrome. I would like to discuss under 3 headings: ST elevation, ECGs in STEMI, ECGs in non-STEMI or unstable angina, and ECGs in few other conditions. ECGs in STEMI. STEMI, as I told you, it is an occlusion of a coronary artery with transmural involvement. That means full thickness of the myocardium is involved. So initially, you get subendocardial ischemia. During that phase, ECG presents with a symmetrical and tall T wave with a prolonged QT. Sorry. This can be transient and usually last few minutes. And then it develops into transmural ischemia, where the whole thickness of myocardium is involved. Then you get injury pattern in the ECG, that is ST elevation. And if the ischemia persists for a long time, then myocardium goes into necrosis. Then you get necrotic pattern of necrosis of ECG in the ECG. You get Q waves of necrosis and negative T wave T inversions. So this is just a diagram explaining these changes. This is normal myocardium. During subendocardial ischemia, you get a tall, symmetrical peaked T wave and a prolonged QT interval. With involvement of transmural ischemia, you get the ST elevation, and with necrosis, when it goes into necrosis, you get Q waves and T inversions. So ST elevation is typically, the typical pattern of ST elevation in STEMI is, it should be new ST elevation at the level of the J point in at least 2 contiguous leads, and it should have more than 1 millimeter in, at least 1 millimeter in all the leads except V1, V2, where new ST elevation should be greater than 2 millimeters in men. If less than 40 years, it should be more than 2.5 millimeters and greater than 1.5 millimeters in women. And usually ST elevations are convex to upward type. So these are, this I have already explained. With the initial subendocardial ischemia, you get tall T waves and prolonged QT, and then ST elevation convex upwards at the J point. And usually it should be at least 1 millimeter from the isoelectric line. And then with time, with hours, this ST segment comes down, and you can see the T wave inversion is forming now. And now after several days, Qs are developed, and then ST segment is resolved, but T inversions are, Qs and T inversions are persistent. Because we are now going to identify the localization of STEMI, it's important to know the coronary, a little bit of coronary anatomy also. You know, on the left system, we have left main coronary artery, which comes and divides into left anterior descending, LAD, or left circumflex. LAD gives branches to diagonal and septors, and circumflex gives to OM branches, gives rise to OM branches. And on the right side, right coronary artery, it comes and if the right coronary is dominant, it gives rise to PDA, and also RCA gives rise to RV branches that supplies right ventricle. Just to mention a few things about ECG leads also. I'm not going into full details of the ECG, but you need to recognize the leads of the standard 12 lead ECG. We have, as I told you, 12 leads in our standard ECG, because heart is a 3D structure. You get leads on the horizontal plane and also on the frontal plane. In the horizontal plane, we get chest leads from V1 to V6. You can see that V1 is on the right side of the sternum. Rest of them are on the left side of the sternum. And V1 and V2 are usually, V1 actually looks at mostly into the right ventricle and also the part of the interventricular septum. V1 and V2 also looks at the interventricular septum. And these leads actually detects the electrical activity coming towards them. And they sort of look at the left ventricle. And you can see V5 and V6 are actually lateral most leads. And then in the, there are other leads that even though those are not done in standard ECG, we have right-sided leads and also posterior leads. Posterior leads are, ECGs are recorded when the leads are attached on the back of the chest, and the leads on the right side for the right-sided chest leads. For the in the frontal plane, you have AVR, AVL, and AVF. AVR actually is looking from the right upper limb, and AVL looks from the this side from the left upper limb. And these AVL and L1 actually looks at the lateral wall of the ventricle. And these leads, 2, 3, and AVF, they look at the inferior part of the heart. And these localizations are important in the next step of interpretation of ST elevation. So, depending on the lead involved, that means in which, depending on the leads that the ST elevation occurs, we can localize into septal, anterior, anteroseptal. Likewise, as you can see, if V1, V2 are involved, it's called septal STEMI, and V2 to V5, it is anterior STEMI. If it involves V1 to V4, then it is anteroseptal, named as anteroseptal STEMI. And from V3 to V6, L1 and AVL are involved, it is called anterolateral. If whole chest leads V1 to V6, and also if the lateral leads are also involved, it is called extensive anterior STEMI. And if the inferior leads are involved, it is inferior STEMI, 2, 3 AVF. In addition to inferior leads, if lateral leads are also involved, it is called inferolateral STEMI. And posterior STEMI is diagnosed when ST elevation occurs in posterior leads. Those are V7, 8, and 9. And RB infarction is detected when there is ST elevation in V4R, which is a right-sided lead. If you can look at this ECG, I hope you can appreciate that there are tall T waves in V2 to V4, and there are Q wave formations in V1, V2, and ST elevations from J point more than 1 millimeter in V1, 2, 3, 4, 5, and ST elevation in L1 and AVL. So anterior and lateral leads are involved, and there are ST depressions in L3 and AVF. These are called reciprocal changes because you detect ST elevation or injury pattern in the anterior leads. The leads opposite to them gets ST depression. Those changes are called reciprocal changes. So these same things that I have told you. So the diagnosis here is anterolateral STEMI, ST elevation MI. This is the same patient's ECG after 30 minutes. Now you can, even though the previous ECG does not show clear ST elevation, here the ST elevation is quite clear, involving all 6 chest leads, V1 to V6, and L1 AVL with ST depression in L3 and AVF, indicating extensive anterolateral STEMI. If you have a look at this ECG, you can see obviously ECG is abnormal, and there are massive ST elevations in V1 to V6 and also L1 and AVL, and there are significant ST depressions in inferior leads. This type of ST elevations are called tombstone type of ST elevations. You all know about the tombstones in cemeteries. So these morphology is like tombstone. And this again, ST elevation involves V1 to V6 and L1 AVL, and it is called an extensive anterior STEMI, and this indicates large area of significant severe ischemia. If you have a look at this ECG, again you can appreciate that there are tall T waves in V1 to V4, and there are some Q waves formation in V1 to V3 actually, and then ST elevations in V1 to V6, but there are no ST elevations in L1 AVF, and there are ST elevations in 2-3 AVF. In previous ECGs, you saw ST depressions in inferior leads. Here you see ST elevations in inferior leads. So it is antero-inferior ST elevation MI. This occurs mostly because this occurs due to LAD, which not only supplies apex, but also the inferior part of the inferior wall of the LB, because LAD comes and wraps around the apex. So this antero-inferior STEMI pattern occurs because of this wraparound LAD involvement. Now, in this ECG, you can, I think, appreciate that there are Q waves in V1 to V3, and there are ST elevations in V1 to V3, and T inversions, significant T inversions, V1 to V5, and also the same changes in L1 AVL. This is actually due to a previous anteroseptal or lateral ST elevation myocardial infarction. I told you that with time, ST segment get resolved and Q waves form and the T's are inverted. This is the ECG of a patient who had ST elevation MI 2 weeks back, but you can see there are ST elevations in V2 to V4 which are persisting. This type of persistent ST elevation occurs due to LV aneurysm formation, which is a complication after ST elevation MI. So you all know, apart from ST elevation MI, acute MI can have the ECG pattern of left bundle branch block. If it is new onset, it's considered as acute MI. But if a patient comes with chest pain who is already had a pre-existing left bundle branch block, how are we going to diagnose STEMI? We use this Gabosa criteria for that. You all know in left bundle branch block, you get negative QRS complexes in V1 to V3 and positive QRS complexes in lateral leads like L1 AVL and V5 to V6. In leads where the QRS complexes are mostly negative, you get ST segment elevation in normal LBB. In leads where QRS is positive, you get the opposite of ST segment depression in normal left bundle branch block. In MI patients, you can detect MI left bundle branch block if the ST elevation in leads where QRS complexes are positive, if there is ST elevation of more than 1 millimeter, that is significant and considered to be MI. That is what we call concordant ST elevation. That is QRS complexes are positive and the ST elevation also, ST segment also elevated, and it is more than 1 millimeter. In leads where QRS complexes are negative, mostly in V1 to V3, usually you get little bit of ST elevation there, but if ST depression occurs more than 1 millimeter, then that is also significant. And if the ST segment elevation is more than 5 millimeter in these same leads where QRS are negative, then that is also considered to be significant and considered to be acute MI. I'm not sure whether you can see this ECG. I'm really sorry, I got this from a website. You see that in V1 to V3, there are negative QRS complexes, and then there are ST depressions there. And V4 to V6 with positive QRS complexes, there should be usually ST depressions in LBB, but you get ST elevation there. And also 2-3 AVF, there are ST elevation. So this is considered to be acute ST elevation MI in LBB, pre-existing LBB. So, as I told you before, apart from these anterior leads, if the lateral leads, those are L1, AVL, and V5 and 6 are involved, that is called lateral STEMI. And in lateral STEMI, you get reciprocal changes in inferior leads, L3 and AVL. If only the L1 and AVL are involved, not without V5 and V6, that is called high lateral ST elevation MI. That occurs due to occlusion of diagonal artery, first diagonal artery. And as inferior STEMI is when ST elevation presents in inferior leads, those are L2, L3, and AVF. And usually you get a reciprocal ST depression in AVL. And inferior STEMI can occur occlusion from all three arteries, that is from occlusion due to occlusion of RCA or left circumflex, or from LAD if it is a wraparound LAD. I'm sorry, I just want to mention that I think I have given you the handout of these slides. I removed the I removed few slides. One is this how to differentiate LAD occlusion at the how to differentiate the sites of LAD occlusion, whether it is before septal, before diagonal. I thought it was too much at this level, so I removed that. But you can, of course, refer the handout if you want to get more knowledge about that. So inferior STEMI can occur due to right coronary artery and left circumflex, and also due to wraparound LAD. But is it possible to get an idea whether inferior MI due to RCA or LCX by looking at ECG? Yes. RCA usually supplies the medial part of the inferior wall and including the inferior septum. So the injury current is directed inferiorly and rightward. Therefore, ST elevation is more in L3 than L2. And there will be reciprocal ST depression on the lateral lead L1. And because RV, the branch that supplied right ventricle can be occluded with RC occlusion, there can be signs of right ventricular infarction, which are ST elevation in V1 and V4R. In LCX occlusion, LCX usually supplies the lateral part of the inferior wall and the left posterobasal area. Therefore, injury current is directed inferiorly and leftward. So, ST elevation more or less same in both L2 and L3. In RCA, it is more ST elevation in L3. And there won't be any reciprocal ST depression in L1 because current is directed towards left side. And there will be signs of lateral infarction rather than right ventricular infarction, where you get ST elevation in lateral leads L1 AVL or V5 to V6. If you look at this ECG, you can obviously see ST elevation in 2, 3 and AVF inferior leads. And there are some ST elevations in V1 to V3 also, and ST depressions in lateral lead L1 and AVL. And you can appreciate that ST elevation is more in L3 than L2. So this is RC occlusion with possible with associated RV infarction, because there is ST elevation in V1. To confirm RV infarction, we need to record the right-sided lead, which is V4R. So in this ECG with inferior STEMI, obviously there are ST elevations in 2, 3 AVF, and you can get reciprocal changes in AVL, but L1 is more or less isoelectric and no signs of RV infarction. And ST elevation and L2 and L3 more or less same. Definitely L3 is not more than L2. So this is due to LCX occlusion. As I told you several times now, RV infarction usually comes with inferior STEMI, and it is suggested by several criteria. Commonest one you want to know is that ST elevation in V1, and it is confirmed by presence of ST elevation in right-sided lead, which is V4R. That is the one we usually record. Posterior STEMI, because in standard 12 lead ECG we don't record posterior leads. Those are V7 to V9, but you can see changes in V1 to V3. V1 to V3 are anterior leads. You get horizontal ST depression. It's more like a reciprocal changes, because V1, V3 faces the posterior leads. They are the opposite of the posterior leads. So you get horizontal ST depression and tall, broad R waves, upright T waves, and dominant R wave in V2. And the diagnosis is confirmed by ST elevation and Q waves in posterior leads. Those are V7, V8, V9. In the ECG, you can see those changes, ST depressions in V1 to V3, tall R wave and upright T waves. And there are some ST elevations in L2 and L3 AVF also. So this is due to posterior STEMI. And if you record the posterior leads, V7, V8, and V9, you can see ST elevation there. These changes are called mirror image of posterior leads, because if you these are the just opposite of the ST elevation that occurs in posterior leads. When a patient comes with ST elevation in ECG, is it always due to ST elevation MI, acute coronary syndrome, or because these ECG patterns can occur with other conditions? For example, tall T waves can occur with various conditions. For example, left ventricular hypertrophy, stroke, hyperkalemia can cause peak T waves. ST elevation, those are also can occur with various conditions like pericarditis, hyperkalemia, Brugada pattern, and Takotsubo syndrome. So we come to the next part of the lecture, that is ECGs in non-ST elevation MI and unstable angina. Do you have any questions, or shall I continue?
Yeah, I think there's one question raised down by Dr. Surang.
Where can I see this?
No, he will ask. Dr. Surang, can you unmute and ask the questions? You're raised down. I think he's not responding. We will go ahead.
Yeah, so at the end you can ask questions. I just want to make sure that you all are all right up to now. If I'm too fast, please let me know. Then I can slow it down a little bit. Okay, so non-ST elevation MI and unstable angina, these two entities are actually differentiated by troponin elevation. In non-ST elevation MI, troponin is elevated. In unstable angina, it's more or less normal. And in these two conditions, you get ECG patterns of myocardial ischemia. There are two main ECG patterns. One is ST segment depression, and the other one is T wave flattening or inversion. Those are the common changes that occur. There are other ECG patterns also, like hyperacute T waves or pseudo-normalization of previously inverted T waves. That means if the ECGs are negative, T waves are negative in previous ECGs, with chest pain, if the T waves are upright, then that is called pseudo-normalization, and that is a sign of ischemia. And U wave inversion, U waves are usually upright, so if they are inverted, that is also considered as a sign of ischemia. ST depression, it can be upsloping, downsloping, or horizontal. Out of these three patterns, horizontal or downsloping ST depressions, if they should be more than 0.5 millimeter at J point. From the J point, it should be more than 0.5 millimeter, and it should occur more than in two contiguous leads. Then it is taken as myocardial ischemia. If we take T wave inversion, it is considered to be a sign of ischemia if should be at least more than 1 millimeter in depth, and it should be present in more than 2 continuous leads, and especially those leads which are having dominant R waves. And if it is dynamic, that means if T inversions were not present in previous ECG and now the new ECG shows T wave inversion, that is significant, and that suggests myocardial ischemia. This is an example of a patient who had non-ST elevation MI who presented with chest pain, and you can see widespread ST depressions involving more than several leads from V2 to V6 and L1 AVA to L2 also, and patient is having sinus tachycardia. This patient was managed as non-ST elevation MI. Again, like in ST elevation MI ECG changes, even with the ECG patterns in non-ST elevation MI, there can be several other conditions that can give rise to similar ECG patterns. For example, ST depression can occur not only in ACS, but can occur with LVH due to digitalis effect, hyperkalemia, and negative T wave can occur with cardiomyopathies, CVA, and hypertrophic cardiomyopathy. These differential diagnoses are highlighted just to make sure that, just to tell you that all ECG changes are not due to acute coronary syndrome. Now, I want to highlight a few ECG patterns which I thought very important, and those ECG changes should not be missed. One is Whelan syndrome. I think you all know about these ECG changes. Deep venous T wave, and the other one is ST elevation in AVR. Whelan syndrome, in ECG, you can see biphasic or deeply inverted T waves in V1 to V3. It is considered to be highly specific for critical stenosis of LAD artery. It's usually accompanies with isoelectric or minimally elevated ST segment, and there's usually no precordial Q. There are no precordial Q waves, and R wave progression is preserved. There are two types, type A and type B. Type A is where the T wave inversion is biphasic, and the type B is T wave inversion is deep and it is symmetric. You can see the type A valence pattern where you can see the T wave inversions in V1 to V3 leads, also V4 here, with biphasic pattern. And I'm sorry, this ECG is not very good quality. Again, symmetrical deep T inversions in V1 to V4 leads. This indicates possible, most likely critical LAD stenosis. Deep venous T wave is a tall, prominent, symmetrical T wave in precordial leads. These T waves are preceded by upslope in ST depression. Mind you, upslope in ST depression at the J point, more than 1 millimeter at the J point in precordial leads. And there are no ST elevation. There can be reciprocal ST segment elevation in AVR, and this is usually either preceded or followed by typical ST elevation morphology. It is considered to be anterior STEMI equivalent that presents without obvious ST segment elevation. So you can see deep venous T wave, there are tall symmetrical T waves preceded by upsloping ST segment. Here is an example of the ECG, tall T waves with upsloping ST depressions in precordial leads, V2 to V5, and there is some ST elevation in AVR as well. ST elevation in AVR, if it is associated with ST depressions in multiple leads, and it indicates subendocardial ischemia. You can see here, ST segment in AVR lead is elevated, and there are ST depressions in almost all chest leads and in inferior leads. It can indicate left main coronary artery stenosis or critical proximal LAD artery stenosis, but this pattern can also occur with severe triple vessel disease or severe subendocardial ischemia due to hypoxia or hypotension. In acute coronary syndrome, patients can have arrhythmia also in ECG. I think tachy and bradyarrhythmia will be covered separately, but I want to highlight two arrhythmic patterns just to introduce you to that rhythms. One is accelerated idioventricular rhythm. It's actually because of ectopic ventricular pacemaker, of which the rate is more than the rate of sinus node. It's a regular rhythm. QRS complexes are broad, usually more than 120 milliseconds, and rate typically is between 50 to 120, and there can be fusion and capture beats. This occurs due to, especially in the reperfusion phase of acute ST elevation MI. It is usually well tolerated, benign, and self-limiting arrhythmia. You might have seen this arrhythmia, especially after reperfusion, after thrombolysis or primary PCI. You can get this idioventricular rhythm. Sometimes if there is spontaneous recanalization of STEMI, even without reperfusion therapy, patients can have this accelerated idioventricular rhythm. This is an example of that, where you get a broad complex regular rhythm, rate less than 120. You can see there are no P waves. So this is an indication of, this is a type of reperfusion arrhythmia. I just wanted to highlight this arrhythmia also, which is a bradyarrhythmia. I hope you can appreciate that there is complete heart block, because you can see P waves here, 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 and here, without any relationship to QRS complexes. This is complete AV dissociation due to complete heart block, and it is due to inferior STEMI. You can see ST elevation in 2, 3 AVF, and also there are ST elevation in V1 to V3. So this is inferior STEMI with complete heart block. Actually, I just wanted to show this ECG because when patients present with complete heart block, we just pay attention to that only. We can ignore this. We might not see this ST elevation in inferior lead. So it is important to look at the ECG if patient has complete heart block to make sure that it's not due to inferior STEMI. There are this is the last part of my lecture. I wanted to highlight few conditions where ECG can be misleading, because in these conditions, ECG changes are not due to acute coronary syndromes. One is benign early repolarization, and there are some other conditions. ECG changes occur not necessarily due to acute coronary syndrome, like pericarditis, aortic dissection, pulmonary embolism, hypertrophic cardiomyopathy, and cerebrovascular accident and SAH, Brugada pattern, and of course, importantly, wrong lead placement. I will go through these conditions very quickly. So, benign early repolarization shows ST elevation in ECG. We identify them as high takeoff or J point elevation. These ST elevations can mimic pericarditis or acute ST elevation MI. Those are usually concave ST elevation. And two important features are there can be notching or slurring at the J point, and there will not be any reciprocal changes in these ECG. These benign early repolarization changes are usually benign and mostly seen in young, healthy people. So ST segment change in benign early repolarization is its elevation at the J point and T wave is peaked and asymmetrical. There is a ST segment that shows upward concavity, and it is described as smiley shaped ST elevation. If you can see here, this is the J point slurring and then up concave ST elevation, and then asymmetrical T here, and you can see the smiley type of ST elevation. This is the typical morphology of benign early repolarization. This can be taken as either ST elevation in MI or pericarditis also. And this is the other important feature told you there is some slurring of the or notching of J point, which is also called fishhook pattern. If you look at this ECG, you can see there are ST elevations in 2-3 AVF, and they are up concave upwards. And if you can, not sure whether it is very clear to you, but there is some notch here in the J point. Is this inferior MI? Is it pericarditis, or is it just benign early repolarization changes? Actually, it's not pericarditis or benign early repolarization. It is inferior STEMI, because there are reciprocal changes in L1 AVL and there are ST depressions in V1 to V3. So it is inferoposterior STEMI. In pericarditis, you can see similar type of ST elevation up concave with J point slurring, and these ST elevations occur in many leads, not concurring into a particular area. For example, here ST elevations are in V3, V4, V5, V6, and also in inferior leads, lateral leads. So widespread concave ST elevation, and there are PR segment depression in precordial leads. And importantly, PR segment elevation and ST depression in AVR. Those are signs of pericarditis, and the patient has obviously sinus tachycardia. This again can mislead, and one can diagnose STEMI in this type of ECG. So it is important to know that. Brugada syndrome, there are two types of Brugada syndrome, type 1 and type 2. Type 1 is, or both, in both type, three types of Brugada. All these types you get ST elevation, mostly in V1 to V3. In type 1, it's the typical of Brugada, you get Code type ST elevation, which is more than 2 millimeter, and followed by a negative T wave. In type 2, you get ST elevation, which is like a saddle shape, and it is again more than 2 millimeter. In type 3, you can either get curved or saddle type ST elevation, but height will be less than 2 millimeter. So this is type 1 Brugada. You get a curved type ST elevation in V1 and V2 and negative T wave. But I'm sorry, I don't have a type 2 Brugada syndrome ECG here. And if you take this ECG, if you took a glance at this, at first glance, you will see Qs and T inversions in L1 and AVL. One can think this is due to ischemia, honestly, but actually it's not due to ischemia. This is due to wrong attachment of limb leads. Why do I say that? Because there is a positive deflections in AVR. AVR is actually a lead where you get negative deflections. There should be S here, not an R. So, and if there is R here, AVR, it could be due to dextrocardia also. If that is the case, then you get R in V1, and R wave should reduce to S1 in V6. But if that pattern is not here, so this is due to wrong attachment of left upper limb and right upper limb leads. That's why you get these ischemic changes. If you attach the limbs correctly, this patient's ECG will be normal. So that's the end of the lecture. I just want to discuss one or two cases. Those are not difficult one. Let me go through the case number one. This is a 43-year-old male patient who presented with central tightening type of chest pain of more than 1 hour, associated with sweating and dizziness. On examination, patient was not in cardiogenic shock. Peripheries were warm. A little bit of tachycardia, heart rate is 96, blood pressure was normal, and was not in heart failure. Please ignore the backgrounds, but if you look at the ECG, these are the possible answers. One, and is it anterolateral STEMI? Is it benign ST elevation? Or is it non-ST elevation MI? Udita, is it possible to type the answers in the chat? So,
oh yeah, they can
if you like, I can give a few seconds, and you can. I'm sorry, I just saw the message here. Was the lecture unclear?
No, that's okay. I think initially there's a little bit of uncleanness. That's fine. After that, it's resolved.
Okay, sorry about that. I didn't see that message. If you all want to have a go, is it you can type the answer 1, 2, or 3. 1 is it anterolateral STEMI? 2, is it a benign ST elevation? 3, or is it non-ST elevation MI?
Okay, most of them.
I think most of you have got it correctly. Yes, it is anterolateral STEMI because you get ST elevations and Qs in V2 and V3, and also ST elevation in V4, V5, and L1 AVA. And there are slight reciprocal changes in L3 and AVA. Anterolateral STEMI. And case number 2, this patient is a 73-year-old female who presents with severe epigastric pain. If you can go through the ECG, I will come back to it. These are simple questions. So, is it inferior STEMI or is it infero-posterior STEMI? 1 inferior STEMI, 2 infero-posterior STEMI. I don't know if it is not clear. These are L1, L2, L3, AVR, AVL, AVF, V1, 2, 3, 4, 5, 6. Hope the ECGs are clear for you. You can again, if you like. I'm sorry. Someone said Terune. Yes, I think most of you have got the answer correct. It is infero-posterior STEMI. There are ST elevation in 2, 3, AVF, and ST dips in V1 to V3. These are actually real patients ECG, not internet ones. And if you can see that there are AV block, there is an AV block also here. There is a P wave here, P wave here. So 2 to 1 block is also there. Right, case number 3. You don't have to answer that actually. 56-year-old patient with diabetes and hypertension presented with central tightening chest pain of 3 hours. Again, if the ECG is, if it is clear, I will just tell you the answer because I didn't prepare a question as such. This patient is having a little bit of tachycardia, and there are T inversions in all precordial leads, widespread T inversions. Patient's troponin was positive, and patient was treated. These ECG changes were not dynamic, but anyway, troponin was positive. He was treated as for non-ST elevation MI. These are my references. Thank you very much.
Madam, when there's a sinus tachycardia, that's a widespread ST depression can occur without regional effect.
Yes.
In that scenario, can we take it as a acute coronary event, madam?
It depends on the clinical presentation. As I told you, all these ECG changes can have differential diagnosis. Just because the patient has ST depression doesn't mean patient is having acute coronary syndrome. First of all, you need to see whether patient presentation is suggestive of acute coronary syndrome, and if, sinus tachycardia can be a part of that. If the patient is having cardiogenic shock or heart failure, they can have sinus tachycardia, or it can be due to other causes like thyrotoxicosis, sepsis. In those situations also, tachycardia can lead to ST depression. That doesn't necessarily mean it is due to acute coronary syndrome. You have to have other like coronary, better to consider coronary risk factors, and you can do troponin to see whether it is there's a rise in theta. That all these features will suggest whether it is acute coronary syndrome, and also echocardiogram. The investigations like that will help.
Okay.
Say if a patient having a significant elevation of troponin, and patient presents with SOB, not necessarily chest pain, with sinus tachycardia and ST depression, it can be acute coronary syndrome. But if a patient is having fever, tachycardia and ST depression, that is not acute coronary syndrome. Most likely it could be due to sepsis.
Yeah.
And again, sepsis can cause troponin rise.
Okay.
But if a rise in theta is there, that will be helpful to diagnose.
Madam.
Yeah.
In valence type of ECG, madam, should there be a positive R in V1 to V3 with biphasic T inversion in V1 to V3, madam? In that ECG, it doesn't show that positive R in V1.
I'm sorry, which in valence? Let me take that ECG.
Yes, valence type A, I think.
You said this one.
Yeah, there should
yes.
be a positive R.
Yes, positive R wave. Yes, I think that was my mistake. I just went through the internet. Even I have mentioned there in there should be no Q waves. But yeah, that was sorry about that. Actually, it was taken from a website because I just searched for type A valence syndrome, and this occurred because it was a clear ECG. I took it. Yes, there should be R waves. There shouldn't be Q waves.
Thank you, madam.
Any other questions, please? Yes, Dr. Premaratne, you can go ahead. Please unmute yourself and you have to unmute yourself, please. Still, we can't hear you. No, hello? We can't hear you. Now we can hear you.
Yeah, there have been several times. I heard the J point in ECG. Can you, madam, precisely what is J point? Hello.
Hello.
Yeah,
I think.
In the ECG, there you mentioned several times regarding that J point. Precisely, yeah. What is the J point?
A point is actually that is the place where the ST segment. Hold on. This is where the ST segment start to like it could be elevated, depressed, or isoelectric. That's the place it starts. So at J point, if it is in normal, it could be isoelectric like this, but it can be concave, elevated like this, or convexly elevated, or it can be depressed like this. So that's the beginning of the ST segment.
Madam, excuse me. In case of valence type of ECG, is it common in hypertensive patients?
I'm not sure whether there is that. I don't know whether there is a specific association like that. But as you mean, just can it be caused by hypertension itself? Is that the question?
Hypertension and the critical LAD obstruction both.
Yes, that can happen because hypertension is a coronary cardiovascular risk factor. So in hypertensive patient, if they develop atherosclerotic disease, they can have, if the LAD is critically stenosed, then can have valence type ECG.
That means valence is not typical for the LAD, critical LAD obstruction.
I would say, I'm not sure about percentage wise, not specific, but it can occur most, it is significantly, signifies that LAD
And Can I add? I'm Guruparan here.
Yes, sir.
Yes, I think what we see in left ventricular hypertrophy, especially if it is a symmetrical hypertrophy, is T inversions in V4 to V6. And as Dr. Sandamali said, what we see in balance is a T inversion in V2, V3, V4. So the leads are slightly different. However,
was that the question? I thought whether they can hypertension itself.
Having said that, in apical hypertrophy, we can have a similar picture to balance syndrome. So that is another caveat when we diagnose balance syndrome.
Excuse me, madam.
Yes.
If a patient comes with LV strain pattern, he's already with LV strain pattern with MI, how can we differentiate?
It will be bit difficult because you get downsloping type of ST depression and T inversions with LVH and strain. But if you can have a previous ECG to compare, then if there is ST segment worsening, then you can suspect acute coronary syndrome. And also with other factors like clinical presentation and troponin will help you there. Otherwise, there's no criteria to say.
Any other questions? Okay, in the absence of questions, I think we are going to conclude this lecture.